one of these days it'll just work, easily, right? First time we've ever done this. So thanks everyone online and in the room today. We're in March already. Oh my gosh, so almost basically spring. So welcome. Today's March 20th. We're having our IQ Forum today. This is on community health workers, challenges and opportunities. I'm Stacy Farr, and alongside John Spurtis and Pat McDonald, kind of co-direct the Healthcare Institute for Innovations and Quality at UMKC. So excited to have you all here today. It's a great, timely topic. And we do want to make sure we thank all of our IQ partners in the forums. This obviously is a part of UMKC and Frontiers Clinical and Translational Science Institute, but also we want to thank Health Forward Foundation as well as BioNexus KC for their partnership and support. So just really high level, I know I'm not going to go in depth about the Institute, but for a little bit of background for those who are not familiar, the Healthcare Institute for Innovations and Quality has this vision of having Kansas City delivering the highest value, most equitable healthcare in the nation. And our mission is really to catalyze and facilitate these multi-stakeholder collaborations so that we can actively improve the quality and value of healthcare here in Kansas City. And then, one of our main projects, we do, a number of different things in the Institute, regional quality improvement, and we do training and education. But you're all here today for the IQ Forum, which is kind of the third leg of that stool of the activities we do. This is our layout of programming for the year of our IQ Forums. And obviously, you are all here today on the community health workers challenges and opportunities. So thank you. Kind of see what's coming down the pike here. And so just a little bit of background before I kind of turn this over to the rest of our speakers, a little bit about community health workers in general, baseline definition. This is from the APHA, the community health workers section, just on that CHWs are really these frontline public health workers who are trusted members of and/or have an unusually close understanding of the community they're serving. And it's really that kind of trusting relationship that allows them to be a great, liaison or link between health and social services and the community to facilitate access to those services and improve the quality and cultural competence of service delivery. And as many of us know already, but CHWs provide a number of services or activities, including, outreach, community education, informal counseling. Stacey, I have to stop you. It's showing on, and it actually is. And it actually is not, as I said. Yeah, so let's take a little gander. Sorry about that all. Thanks for letting us know. There you go. We'll just see if this is where then we couldn't advance though, which makes me nervous. Okay, that works now. Everyone online can see? Yes. Okay, perfect. And then, so continuing on the services, we had said, informal counseling, social support and advocacy, as well as screening. And from kind of, this is from the World Health Organization, and it's actually a really dated statistic, so I don't know, there's probably much significant number now, but there were, sorry, it shouldn't be a dollar sign either, much more than $1.3 million because there are 1.3 million CHWs that are currently working in the world. Just shows what an in-demand position this is. And then in terms of, specific to the US from the Bureau of Labor Statistics, there were an estimated 63,400 US jobs in 2023 with an expected growth over the next 10 years of 13%. So this is, an in-demand profession for a number of things. Sharing that. And then I know our speakers will give us a lot to think about. And but I wanted to share also for those who want to dig in even deeper, there was an interesting special issue in Health Research and Policy and Systems Journal about community health workers at the dawn of a new era. And this snapshot is just a picture of, the editorial, but there were actually, 11 different papers in that series that kind of talked about different angles within this. So if you're, in the field interested in this topic, et cetera, and want to learn more, I think it might be a great resource for you all. But they talked about, I wonder if I can minimize. We can see the slides actually. Talked about tensions for CHW programs, talked about planning, coordination, and partnership, The series covers program governance, some of the issues, program financing, CHW roles and tasks, the recruitment, training, and continuing education of CHWs, CHW supervision, incentives and remuneration. And then the CHW relationship with both health systems and the community was covered, as well as program performance and assessment, and the CHW's role for health for all. So just an interesting resource to take advantage of. But I know we're going to learn a lot from our really great panel today. So today we have a really great panel and lineup of speakers. We have, I won't read them in, well, I guess I could, but we're going to start with community health worker perspective on patient advocacy and health disparities. And so it's really great that we're going to kick off our forum hearing directly from a CHW who's working in this position in the field. And that's really a great honor for us to be able to have that here today. So we'll have Sharita McKenzie presenting first. And then we'll have an independent home-based care perspective from Timothy McNeil, the CEO of Freedman's Health Consulting, then a nonprofit perspective with CHWs at the heart of the clinical and community linkages with Christy Bowling-Demetz, who is with the Mid-America Regional Council, as well as Hannah Eid. Hopefully I said that right. Okay, good. And I remember you. Good to see you again. Also from Mid-America Regional Council. And then we'll be having the association and credentialing perspective of CHW training and opportunities for collaboration with Suzanne Smith. So really great lineup. And with that, other than, we'll pull this up later, but, save the date for the next IQ forum, obviously in May on generative AI. But with that, I will stop my slides and turn it over to our first speaker.
We should read the slides.
Yes, and I will find those. They're sitting down here.
They're shown wonderfully online.
Give me a nice little ding. I'm at the beginning already, so apparently it lets you know that. So nice. All right, and then, my pleasure to introduce Sharita McKenzie, a community health worker, a breastfeeding support specialist with Swope Health. So, yes, the floor is all yours, and you should be able to either hit, down or the space bar through your slides.
Yeah, thank you so much. Hello, you guys. It is a pleasure to be here. It's a pleasure to speak with everyone. Totally an honor. I'm coming from Swope Health as a community health worker, and I do work in family medicine department, and we're with the population health department as well. So just get started. So with this is my first time doing this. Just bear with me. But we'll go over our mission and then also our vision, of course. So Swope Health improves the health and wellness of the community by delivering accessible, quality, comprehensive patient care. Our vision, to be a regional healthcare provider of choice in the communities we serve. But I really want to zone in on the fact that we like to make care visible. So we make that visible by having an actual community worker in the departments that we are in. And so that we're boots on the ground and at the front line with the community that we serve. Just wanted to introduce that. Go over with the agenda. The agenda that I have is just my introduction, of course. What is the CHW? They clearly outline what the CHW is, the importance of patient advocacy, breaking barriers and the challenges that we face as community health workers, and then also addressing the social determinants of health. And if we have questions or anything that you guys want to go over, then we can go over those as well. And like we introduced, I am a community health worker. I've been a community health worker for about 2 years. I've also done breastfeeding support specialist. And then I have developed peer-to-peer support groups for mental health for anyone that is interested in those. So I've decided to do that on my own. It wasn't anything that anyone told me to do. So I just wanted to do that for everyone in the community. So I really just want to dive right in. It may not take up to about 15 minutes, but I'll just dive right in into breaking our barriers and the challenges that I'm seeing that are being faced with our community members. So while working with community members, there have been many barriers that may stand in the way of improving their overall health and the concerns that we have. So what I've noticed with most of our community members, we can call them patients, they can be clients, but some of the barriers that they do have is that they're the homelessness that we face right now. And housing guidelines, the restrictions that they have, the transitional housing that I've come across. So, and some of this is just getting access to care and their reliable resources that we try to offer to them. So, and then it's easy for us to just hand off resources, but we want to know that the resources that we do give off are reliable. So that means that we are contacting the organizations to making sure that the numbers are correct, or all of the things that the providers in our MAs that they're not able to do, that we can go ahead and do that with the community members. So the food pantries that we're noticing, that we have food pantries, but the issue is that the transportation, our community members do not have all of the access to the transportation. We do have public transportation, but we're noticing now that they do not go to all of the areas that cross the state lines that we have. And so when we do see them and when we offer these resources, not a lot of times that they're able to get to them. We have to develop a way to get the resources to them. And then also assistance with navigating the systems that we have. So that can be Medicaid application. This can be just going to know directions to where they need to go. A lot of times when they do come in and they're seeing the providers, a lot of times they just need help on navigating systems. And so that's where the community health worker will come into play. Mark, myself will go ahead and we'll sit down and we'll partner with them so that we can assist them with the things that they need. So, and then moving forward, so we're hoping for a future of creating connections with continuous advocacy with the patients and clients through community health workers and organizations. So this would just, the biggest part for me is building trust within the community and the resources that they have. And that is the most significant part for me, is to be able to build the trust with them. So then once we can build the trust, we know that they will come back. They'll have more routine appointments that they have. So, and then both provide a safe space, both physically and mentally, for community members. So we just want to be able to do that with them as well. And then we also want to bring awareness to the providers and the community members, so then they know the significance of having a community health worker. That's the biggest thing for me. The parts that I wanted to go over, the resources and the advocacy and how important it is for them, and just bringing that awareness to everyone so that they do know. But these are my slides. This is what I wanted to go over with you guys and just present and let them know about the awareness of having a community health worker, so that we know. Could I hand it? Awesome. Okay. Thank you.
Thank you. Perfect. Okay, wonderful. Thank you, Shida. And so now we'll move to our second speaker, which is online, correct? So I don't need to share slides. Okay, so I'm going to minimize these. Okay, so our next one is Tim McNeil. And Tim is going to be presenting the independent home-based care strategist. It's okay, I'll get it one of these times. Perspective. Strategic strategist. We'll do them both. Anyway, so Timothy McNeil is Chief Executive of Friedman's Health Consulting. And Tim, I'll turn it over to you to go ahead and share your presentation with us.
Great. Thank you so much. I'm going to share my slides. First, I'm going to start just by highlighting the current evidence around the business case for community health workers. So a lot of my work revolves around making the business case for deployment of a community health worker model to drive outcomes. And the largest demonstration to date was something called the Accountable Health Communities Model. And that Accountable Health Communities Model was a CMMI, Centers for Medicare and Medicaid Innovation demonstration. It occurred over 5 years. As of late, I continue to highlight that this entire model was implemented during the first Trump administration. So it began in 2017, and it was the largest ever of its kind implementation model around screening and addressing health-related social needs, with an evaluation to test the financial impact of doing that. The third evaluation report has been released, and there's significant findings in the third evaluation report. And the data was significantly conclusive that showed that deploying community health workers is not just a good idea, it's a firm business model. And so the data showed that the intervention of screening for health-related social needs and addressing the social needs had a direct impact on total cost of care. So amongst the populations and the population size that participated in this demonstration was substantial. Over 1 million Medicare and Medicaid beneficiaries participated in this demonstration in multiple markets across the country. That included Texas, southern states, Northeastern, Pacific Northwest. So a broad swath of the community, of the nation, participated in this demonstration. And the initial hypothesis of this demonstration was we would identify Medicare and Medicaid beneficiaries who had social needs. The community health workers and other interventions would be deployed. And then when their social needs were completely resolved, we would likely see financial impacts. The data actually showed before their needs were fully resolved, the impact of having someone screen, address your needs, and begin working with them over the course of that continuum to solve their needs, we saw impact in their total cost of care, even if their social needs were not fully resolved. And with the analysis, it really showed where the only intervention that was brought to bear that changed things was the community health worker intervention and screening for social needs. So we then use, and I'm part of I'm based in DC, and I was part of a federal task force looking at pathways to sustainability for community health workers. We use that data to create its first of its kind clear pathway for reimbursement for community health worker labor. So that led to changes in the physician fee schedule in 2024. So there's now currently, and these are final rules, a Medicare Part B benefit for addressing health-related social needs as a Part B benefit. And that applies to all persons with original Medicare. Since it is a Part B benefit, Medicare Advantage plans and special needs plans have a statutory requirement to cover all Part A and Part B benefits. So that population is also included. Oftentimes, I work with groups and they ask about, the most vulnerable with the worst health outcomes. In many markets, that was dual eligibles. Dual eligibles have the worst outcomes, and they're fully covered by this benefit. And as a Part B benefit. And it also allows federally qualified health centers and rural health centers to receive this reimbursement on top of their prospective payment system or all-inclusive rate as an RHC. So there's 3 separate benefits, and I'll describe each. So that first column with the navy blue at the top, that first benefit is called community health integration, and it provides reimbursement for labor expended to address identified health-related social needs for a Medicare beneficiary. So it allows the provider, the qualified practitioner, to deploy auxiliary personnel to address the needs. The rules specifically state that those auxiliary personnel can be community health workers or other staff, and they gave a listing, things like social workers and others. So it's not exclusive to community health workers, but the rules specifically call out community health workers as an ideal workforce for this intervention. So the logistics of it, there needs to be an identified need. The need should be part of the problem list. And then there needs to be a plan developed to address their social need. There does have to be a connection between the social need and the expected outcome. For example, I often give is diabetes. A person with food insecurity and diabetes, if the clinician's trying to get their A1C down to 7, but unfortunately they're eating peanut butter and jelly and noodles every day because that's all they can afford, then they will likely never achieve that A1C of 7, regardless of how many prescriptions we prescribe. And so therefore, we need to deploy an intervention to address the food insecurity because that's the most cost-effective intervention in that example. The second benefit in the middle is called principal illness navigation. And that provides reimbursement for providing navigation for persons that have a serious high risk condition that's expected to last at least 3 months and could lead to worsening health outcomes, regardless about whether or not there is a social need present. So community health integration, the qualifier is the social need. Principal illness navigation, it does not depend on a social need, but they must have a serious high risk condition and they can benefit from health navigation. CMS gave examples of this, such as cancer, dementia, persons with multiple chronic conditions, where they're unsure of how to navigate the health system. You can match them with a community health worker that can help advocate on their behalf and help navigate them. And then the time spent is reimbursable under these codes. And the last column is principal illness navigation peer support, and that is a set of codes specifically for persons that have a behavioral health or substance use disorder, and the labor force would be certified peer support workers. Here is a listing of all of the interventions that are reimbursable based on time. All of them have equal weight, and whenever these services are deployed, then the organization can receive reimbursement and the labor force can be community health workers to deliver this. And again, this is a benefit that's live on the books. It's in the final rules in 2024, and CMS reiterated the importance of these in the 2025 fee schedule. And so if I take some of the ones that are highlighted, they're highlighted not because they're more important than the others, but just to give a picture of how expansive these rules are. It provides reimbursement for facilitating access to community-based social services, coordinating transitions of care, particularly when a social need impacts that. So for those that work with hospitals, a frequent problem is how to discharge someone with complex needs and housing insecurity. We have to establish a safe discharge, and there isn't a good mechanism to solidify safe housing to facilitate the discharge. This becomes a payment mechanism for that. And then lastly, I want to point out facilitating behavior change. So there was a recent article in the Washington Post, and obviously I'm in the DC market. I want to highlight it. They talked about funding that went to house someone who had a long history of homelessness, but also has significant chronic conditions. They got a housing voucher, placed that person in housing, and 6 months later, they were unhoused again. And the article highlighted that if you just place someone in housing, and you don't take the time to facilitate the behavior change, they will continue to live as if they were homeless, and then soon they will be homeless. So that's why, in their infinite wisdom, CMS thought to add continual support and effort to facilitate behavior change as reimbursable services. And when the community health worker does that, it provides a reimbursement. Here are the billing codes and the reimbursement rates. The rates are the national rates. The rates in Missouri would be a little different, but I just listed the national rates here as a reference. The way to look at these codes, the reimbursement is provided for all the labor spent per calendar month per beneficiary. It is time-based billing, and the time does not have to be spent in one setting, but you bill for the aggregate of time spent each calendar month. So, for example, in the month of March, if we spent 3 hours with a beneficiary, we would bill for 3 hours, but you cannot carry time over from one month to the other month. And there's a minimum threshold before you can bill, and that's 1 hour. So if you take the first set of codes at the top for community health integration, and that is again for reimbursement for addressing a social need such as housing, food, transportation. I deploy a community health worker to begin working with a beneficiary to address their social need, let's say housing insecurity. Maybe they spend an hour in the first setting. Then they had 2 more visits with that person, and those were 30-minute each. So then over the course of the month, they spent 2 hours working with that person. The way that the billing would occur, you would bill the base hour would be G0019, which is for the first 60 minutes. Then for every 30 minutes after the first hour, you would bill another unit of the add-on code. For CHI, that would be G0022. So for 2 hours of community health worker labor to address a social need, then that would be roughly $170 for 2 hours of community health worker labor that would be reimbursed under these codes. So the codes also, I believe, fully recognize the true cost. So it's much more than if I take the median labor rate for a community health worker, which the National Bureau of Labor Statistics says is $25 per hour. Well, in 2 hours of community health worker labor, the reimbursement would be $170. So that takes into account the supervision, the infrastructure, the other things that are needed, the supervision to enable the community health worker to be successful and cover the labor. So this is a clear pathway for sustainability. And why? Why did they create the clear pathway to sustainability? Is because the data from the demonstration during the first Trump administration showed substantially when we do this, there's tremendous cost savings because of the impact of community health worker labor. So thank you for allowing me to present.
Thank you very much. That was really helpful. I learned quite a bit. So thank you so much. And now we will turn over to our nonprofit perspective of CHWs at the heart of clinical and community linkages with both Christy Bullen-Demetz as well as Hannah Eid, both from Mid-America Regional Council. And I will go ahead and share.
Well, can I use that? Let me just skip the slides.
This works. Use what's.
Yeah, we'll just skip the ones that are not loading so we can.
Okay.
Thank you.
Oh, this is great.
Okay, all right. Floor is yours. Thank you.
Thank you. Thanks for having us. This is such an important conversation, and we're going to talk a little bit about all of the places where community health workers work and should be. And Hannah Eid has a lot of great information about community health workers. I'm Director of Aging and Adult Services at the Mid-America Regional Council. This must be which is a nonprofit, but also the metropolitan planning organization in this greater Kansas City area. Closer. So 3 of the things, among others, that we do out of that department include the CHW Collaborative. So I have the great honor of working with Marlene, who's sitting here in front, and Hannah Eid. We are also the Area Agency on Aging for the 5 counties you see in blue. And then we are a community care hub, which you'll hear a little bit more about. But I'm going to turn it over to my colleague, Hannah Eid, to speak more specifically about community health workers.
Thank you, Christina. So happy that other folks were able to introduce CHW, so we can go ahead and skip some more slides and get to other information. I do want to recognize that around 2016 is when the Bureau of Labor the Bureau of Labor was able to recognize CHWs and kind of make that a section as part of APHA starting in the 70s, but I feel like more officially recognized as a workforce in 2014, 2018, and kind of being able to develop maybe more of our scope of practice, which is right around the time where Mid-America Regional Council started supporting our Kansas City Regional CHW Collaborative, which we still meet regularly. It's a multidisciplinary collaboration of organizations. We're here to support our workforce at a regional level, as well as state. We've been able to also work around the region and multiple parts of the nation. We have 3 main committees that are active, including our executive committee, which really steers our plan, our work goals, what we're doing as a collaborative. We have our CHW forum, which we think is really important for CHWs to have a place to be able to network, to build that relationship with one another, learn together, case conference, whatever they might need is led by them, for them. Everything might be what they kind of help us shape the rest of the collaborative as well. And our advocacy committee really promoting who we are, why we're important, why we should be or belong everywhere, as well as being able to have that visibility across whether it's social media or at events and just any opportunity that we have to be able to speak about CHWs. Our focus area is capacity building. So being able to have those defined core competencies that we share in the state of Kansas and Missouri, which is pretty unique. as well as formal training and ongoing professional development, which is important as a professional career, which has led us to be able to have certification in the state of Kansas and credentialing in the state of Missouri. Again, the advocacy being able to promote as the employment of CHW, as well as a career path for folks who are interested in maybe a change or being able to grow. And I apologize, I'm not able to see some of the slide. As a sustainability to be able to, 1 second. I'm gonna try to see if I can. Sorry, yes, there you go. Sorry, it's been cutting off the bottom of the slides. Okay, sustainability of the profession, where we're able to have that workforce and programs. I know Tim also mentioned a bit of the reimbursement, which we have a toolkit that we were able to collaborate with Tim McNeil as well as Erica Selesky, and being able to have, sorry, still can't see my slide. 1 second. All right. Practice integration of CHWs, which is one of the main components that we're working on at this moment, and looking forward to be able to share that with others, which goes along the line with all of the work of the collaborative, tying together the toolkit, as well as being able to link clients to care. I can't, okay. Oh, hey, sorry. I'm able to see better, thank you. There we are, learning each slide. So examples of CHW programs being anywhere with a community-based organization or hospitals, clinics, employed by payers, mental health services, behavioral health centers, even in research, we've been seeing that locally in Kansas City. Which leads us a bit more of what we're talking about for our Mid-America Community Support Network. So I'll turn it back to Christy.
So you've already heard the importance of community health workers working in multiple environments. Certainly the new codes that Tim shared help support those folks that are working within the walls of medicine. That's critically important. However, we know that 80% of what influences those outcomes happens outside of the walls, in communities. So there are a number of community-based organizations that provide these services in the community. They've been there forever. I'm a nurse, so I come from that background of just knowing we can refer out to community resources, but we never really thought about how does the money follow that client to support the services. So CBOs work independently typically, that's great, but it's really difficult to stay sustainable in those moments. So in Kansas City, we have the authors of the Community Care Hub called the Community Support Network in the room, actually. It started in 2018, and I'm just gonna go through all of the animation here. Started in 2018, really was critical during 2020, as you can imagine. And today we jump here around a little bit. Today we are a COE grant awardee, and what that means is the Community Care Hub here in Kansas City was recognized as one of 20 in the country to receive funding for infrastructure and expansion. You'll see the note at the bottom that we were also selected as one of 7 out of those 20 to participate in a care transitions evaluation. So we're really excited to be doing that with High IQ. And the heart failure program that works with a number of hospitals and follow-up in the community post-discharge. So just to connect some dots there, I'm going to back up here a little bit. The model of the Community Care Hub is heavily reliant on community-based organizations and those community health workers that are providing services directly in the community. If you think about an independent physicians association or an IPA, it's a similar model, but for community-based organizations at the foundation. One of the key challenges is sustainability for those organizations. So you heard Tim talk about those codes, and again, those are healthcare codes that have to be initiated by a clinician. Healthcare entities typically are hesitant to heavily work with CBOs because there's volatility in capacity, meaning as funding is there, they hire, they train. As funding goes away, they have to lay off. So there's this cycle going on in the community. CBOs say if we had reliable funding, we could support that capacity and consistency. So we've got a little bit of a dilemma here, and especially at this time of great change. Even though there's a community health worker in the healthcare setting, even though there's a community health worker in the CBO, none of that is really going to matter if there's not funding that follows. And I can give you an example from the Area Agency on Aging. As funding returns to pre-COVID levels, we now have many, many services that are on freeze. So if you're a community health worker, but you have nowhere to send somebody for home delivered meals or transportation, it cripples the work in the community. So something we have to solve for here in Kansas City. I'm going to turn it back over to you for the community health work instead of spending any more time on this, but it is really key for you to understand that in Kansas City, we have this network in place that's growing, and community health workers have to be there. They're the delivery mechanism.
Thank you, Christy. And we can see that how CHWs can support older adults, which is individualized plans. What do they need? How can we help them accomplish those goals? Like Christy said, we need resources as well to be able to accomplish them. Sharita gave great examples of, we might know where a food pantry is, but without having the bus route to get the client there, then they cannot access that food, so it's still not accessible. But having that health education, we have rare examples here in the Kansas City area. I should have started that I was a CHW starting 13 years ago. Just February was my 13-year anniversary. So being able to see this in real life here in this area has been quite tied into everything we're talking about. It's not just like a part of our presentation, but the life that we live every single day. For example, health education, how important it was when I would see someone at the emergency department who thought the diabetes was a 1 month kind of thing, the way you have maybe if you need antibiotics for a whole month and then it's gone and over. That was their understanding of taking something like metformin. They didn't know it was a chronic condition that needed ongoing care, which is why when they went back to the emergency room, their sugars were 500. So we realized that they needed way more steps and touch points throughout their journey than just a one-time intervention or one-time meeting with a clinician. So Tim kind of mentioned this as well when it comes to Medicare's community health integration. And what does that look like? So kind of being part of that care team, Christy mentioned, we're partnering the clinical sites as well as CBOs, where the medical needs are identified by staff and referred to a CBO who's able to enroll people into these programs. We then have time to really be able to dig what else is going on. We know I've been asking folks at hospitals, even recently, even though I know the answer, do you have more time to spend with that patient? If you're a provider, are you able to talk to them to see what's going on? Are you able to find resources on their behalf? Do you have free time? So if you can ask any nurse practitioner, any physician, any social worker at the hospital, ask them if they have free time. And I think everyone knows the answer of what that looks like. So CHW really designed to be able to have that trusted relationship with someone, because there are things that we find out once we're working with people that might be something that you don't bring up in the clinic. Maybe it's something that we might be afraid to speak up or maybe ashamed. We've had folks who don't have fridges at home, which is why they're not storing their medication where it should be. They don't have a bed, and they have had an amputation recently, so they're sleeping on the floor, which is why they continue being in so much pain. So the more we get to know someone, the more we get to find out what is really happening in their lives that is impacting their health absolutely. So working on those tasks as a CHW, as Tim mentioned, throughout the month, depending how long it might take, but really being able to have that communication back with the care team through either the EMR, part of that case conferencing. So really being integrated into as part of kind of one, even though you might be in different institutions, but really coming in as one whole team to provide those cares and services, and ultimately be able to address any of the needs identified and discharge the person into care. We are often seen as magical, but we're also a proven workforce where we're able to see how impactful are we. And one of the programs in Kentucky was able to see a medically underserved area where it was serving, I believe, 2,000 patients. And what I think this was about a year after they were discharged from the program from working with the CHW, they really focused on education. So workshops about nutrition, diabetes, blood pressure, being able to provide transportation services so they could go where they needed to go, and being able to see a reduction in the number of emergency room visits, inpatient admissions, as well as how long are they staying in the hospital, and ultimately being able to save 16, at least cost per patient was decreased almost 17%. And I believe when we were talking about how much are we investing in a CHW and how much are we saving, I think it was about $11. So for every dollar spent on a CHW, the hospitals were saving more than $11 because of that. So we're very efficient at what we do. Of course, we need those resources to be able to function, but the cost savings, even within 6 months of looking after your discharge from a program, I think some of this particular study in New Mexico about MCOs, managed care organizations, was about $2 million that they were able to see that they were able to notice a difference from clients who were able to work with CHWs. They looked at different categories, including the emergency department, inpatient stay, prescriptions of narcotics and non-narcotics. And that's when it was able to see just within 6 months, the cost differential, again, being over $2 million. We've been hearing this throughout, including what Christy shared about sustainable funding being really important for us to continue in our programs, as well as whether it's reimbursement strategies, that blending and braiding of funds. We also want to be able to retain good CHWs that have been here for a while, are experienced, that know what they're doing, they're able to help bring other CHWs as well as empower their own communities. I think one of the things that we see quite a bit is we have really great pilots and really great programs. And if you think about 3 years, sometimes it sounds like a long time, but starting a CHW program kind of from scratch, getting it running and then sunsetting, you kind of feel like you only have about 2 years of really running. And we do make a bit of impact, but we know that needs to be continuous for it to be quite effective. And we mentioned resources quite a bit, availability and accessibility. So whether it's transportation, or sometimes some of the resources take, 300 days to get a response, which is a really long time when someone is in dire need of services immediately, or maybe not being able to connect to them because there's not capacity. You might need a call once a month or only a specific day, a specific time period. People might be working. So it's really important for us to have access to resources to be able to help address those needs. I think we mentioned housing earlier. So you might have a housing voucher, but if no one is accepting that voucher, the person still cannot have placement or be placed anywhere. So they continue having or experiencing homelessness, even with a voucher available, which is actually one of the cases that we've been hearing recently. We get quite a bit of calls and just able to see what's happening. And that's one of the examples that we saw within the last month. And that is actually a QR code that you're supposed to scan that can't see, but I can share that link in the chat. Okay. And I can invite Christy back to thank you so much for having us here today. We want to acknowledge partners who make our collaborative work really important. So which is our Kansas Department of Health and Environment, Health Forward Foundation, and the Department of Health and Senior Services. They've been able to be our partners throughout our journey here in Kansas City, and we really appreciate their ongoing support. I'll just leave that.
Thank you both very, very much for that presentation. And then before we do our next speaker, there was one thing everyone, I guess, online, but in the audience, make notes. I forgot to say is if you have any, questions, thoughts for any of the panelists, you're welcome, those of you online, to drop them in the chat. For you, those of you in the audience, to get excited to ask them in the panel Q&A portion. So, which will be after our final speaker. So with that, we will now introduce our final speaker, who is Suzanne Smith, and she will be presenting the association and credentialing perspective of CHW training and opportunities for collaboration. So very important topic as well. So, Suzanne's online, correct?
Yes.
Okay, so let me just sharing. Okay, great. And the floor is yours, Suzanne. Thank you.
Awesome. Thank you. Can everyone hear me?
Yes.
Awesome. Well, happy spring. Hopefully, spring is here to stay. I know that makes everyone feel much better. I am Suzanne Smith. I'm a community health worker and have been, I say I've been a community health worker before it was actually a designated position, because I've been working in nonprofit all my life and in the community helping connect people to resources. I am a credentialed community health worker. I am the board president of the Community Health Worker Association of Missouri. I am also a member of the Missouri Credentialing Board representing the Community Health Worker Association of Missouri. And as a CHW, I know that we use a lot of acronyms. So SHWAM is the acronym for Community Health Worker Association of Missouri. And then I am also the lead facilitator for the Missouri Telehealth Network Community Health Worker Echo that is held twice a month. So I'm going to talk about a little bit about all of these things as I go through my slides. So some of the opportunities as a community health worker, you may or may not know. You have the ability to attend the 16-week community health worker certification course that is offered by 17 different organizations. It's actually facilitated through the Department of Health and Senior Services. They are the ones that hold the curriculum and work with everyone that are the trainers of this curriculum. The different organizations are throughout Missouri. Some of them are totally online. Some of them are hybrid. You get to go in person some, you get to be online some. Depending on if the organization has a grant, will determine if the certification course is free or if you have to pay for it as if you were going to as a college class per se. So it just depends on which avenue you work with and you get that certification done through. Once you become a certified community health worker, then we encourage everyone to become credentialed. So when we first put the Community Health Worker Association together, which was back in 2017.
Suzanne,
yes.
Can I interrupt you for a second? If you are moving through your slides, it's not moving for us.
Well, goodness. Okay.
You're not in presentation mode, and if you're tabbing down, it's not moving.
Okay, hang on just a second here. Let me go back to, I'm usually in person, so maybe that's my problem. How do I get to presentation mode?
Okay, right where move to upper left corner. If your left is this, okay, now move over one, move over to the right, next one, right there. That'll get, nope, back over.
But, okay.
That's presentation mode.
Perfect. Okay.
Well,
no,
it didn't do what I thought it was going to do.
All right, story of my life here. Okay.
Wait, everybody's. Wait 1 second, Suzanne. Do you think it'll behave better if she goes to the one on the bottom, you all?
No, she just had to flip the monitor, flip the view.
Same steps first.
Or that way works either way.
However, she's not in presentation mode.
Yeah, she just goes back to presentation. There's a swap screen at the upper left.
Okay, now swap screen.
Swap screen. Where is swap screen at?
Display setting. Display setting.
Display setting right there. Swap
How
screen.
about that?
There you go. All right.
Did it move?
It moved, and we're on the page that starts with a bullet, community health worker credentialed. Perfect.
Okay. Sorry about that.
That's okay.
I'm not real technical savvy either. So, so as I'll go back to the Community Health Worker Association. When we were founded in 2017, it was through the Department of Health and Senior Services. And at that time, Barb Brindle was the lady working with DHSS that got everyone together. At that time, we put together different regions across the state of Missouri and worked to find folks in those areas that would like to be on the board of the Community Health Worker Association to represent that particular region. So we do have seven different regions across the state. And our board of directors is made up of someone from every region. Then we have a president, vice president, secretary, treasurer. We have someone from the Department of Health and Senior Services that is the liaison for us. And then we have a past president, and we have someone that is our, what do I want to say here? They're our affiliate to the National Association of Community Health Workers. So we meet once a month. We hold an annual conference, which we just finished up a couple of weeks ago at the Lodge of Four Seasons. Our conference offers up to 14 CEUs, including 3 of the ethics. And as we all know, as we get ready to credential or re-credential, those CEUs are very important. So as the credentialing, as a member of the credentialing board, we have right at 600 community health workers in the state of Missouri that are credentialed, which is amazing. You have to, there is a process to go through to get credentialed, some paperwork that has to be filled out. And then every 2 years, you are required to re-credential, and that re-credentialing has to have 20 CEUs, and 6 of those have to be ethics in person, but that in person can also be a live Zoom. That changed when wonderful COVID hit. We were able to switch that up a little bit. There is a fee with the original credential, and then a fee with the credentialing or the re-upping of your credentialing. So as a Community Health Worker Association of Missouri, we have right at 300 people that are a member of our association. So by being a member of the association, you are offered different trainings throughout the year. We have the conference. When you attend the conference, part of that conference fee goes to your membership to be a part of CHWM. We have an annual meeting. And then you have the opportunity also to help plan the conference as to what would you like to see happening at our conference. So we had over 250 folks attend the conference the first part of the month at the lake. We had 15 different exhibitors that were there. And then we also had, I believe, 7 or 8 different sponsors. So we have really worked to grow this. And we have grown every year since we started being able to be back in person after COVID. So this was year 3. Next year will be our last year at the lake. Maybe. Everybody is starting to say they want to go somewhere else. So we're going to let all of the membership decide next year at the conference as to where the 27 conference will be held at. And that it's very hard to say 27. I'm just not in the right mindset for that. And then the Missouri Telehealth Network, Community Health Worker Echo. If you've not been on one of those are free. You just simply go to the Missouri Telehealth Facebook page, but website, and then you can sign up for a multitude of different echoes if you would like. But the community health worker has been one of the echoes since, I believe, 2016, 17 as well. I've been on that as well from the very beginning. I've been the facilitator, I believe now for year 5. And we have about 7 of us that are on the hub team. We have a different didactic that is presented at every meeting by someone different. And then we actually look for community health workers that are out there, boots on the ground, to bring a case to us that they are having trouble finding the resources for, so that maybe other folks on the Echo might have additional ideas that they have not thought about. Our Echo is one of the most attended Echoes besides the COVID one. We average 70 plus folks that are on our Echo every 2 weeks. So we're very proud of that. And we're also very competitive with the other Echoes as well. So on to the next slide here, as I was saying about becoming credentialed through the board on the CHW ECHO. I talked about becoming a member of SHWM and attending the conference. We also encourage folks, you do not have to be a member of the Missouri's Community Health Worker Association to be a member of the National Community Health Worker Association. There is the NASHWA, and then they have their own meetings and they have their own conference. Their conference is every 2 years. The Missouri conference is annually. The National also puts out a monthly newsletter that only members can receive. NASHWA is a $20 annual fee, which is very nominal. And as I said, to be a member of the Community Health Worker of Missouri, it's actually $50, or if you attend the conference, it's included in that. If you did not attend the conference a couple of weeks ago, you can go to our website and still become a member for $50 by signing up online. Another opportunity for community health workers is you can participate in the quarterly DHSS Statewide Community Health Workers Advisory Committee. Right now, Tiffany Musing from DHSS is the advisor for that. And you don't have to be a member of anything. It's completely free to participate in the DHSS meetings. And they usually have at least twice a year someone that comes on and does a 1-hour CEU that you can grab a hold of as well. So some of the challenges that I see are resources and resource contact changes. So as many folks talked about before, as a CHW, you need to know the resources that you have available in your community and then also in your surrounding communities. But a lot of times the contact for that resource changes, and it's hard to keep up with that. And sometimes resources are not easily acceptable or accessible if it's not something that's listed online. You may not know about it. Sometimes you've got to know Mary to know Jane to be able to know that this church does so-and-so, or this organization will help with rent, or that sort of thing. So that's where, as a community health worker, it's both a challenge and an opportunity for you to be able to go out and network and make those relationships, because the relationships are what it's all about, being a CHW, because it's so much easier to be able to call up somebody and say, hey, Jane, this is Suzanne, and I've got somebody here with me that is needing some help with their housing or their utility bill or whatever. Can we make an appointment for them to come over and chat with you? And that also makes the client sitting there with you feel better and more at ease if they know exactly who they're going to see, and not just you giving them a piece of paper that says, here's all the resources, take it on your own and good luck. Some other challenges has been spoken for already is funding cuts. Everyone is experiencing that at this time. So hopefully things will be looking up in the future here. Another challenge is sometimes not always being able to find the needed CEUs if you are credentialed or if you're looking to be credentialed. Sometimes your organization may not pay for those for you, so you have to fund those out of pocket. I will say that sometimes you can find those at no cost. It's harder to find like ethics at no cost. But the Missouri Credentialing Board does offer a whole plethora of different trainings online that you can sign up for, and they're pretty nominal. An ethics course I just saw the other day was $22 for 3 hours. That gets you 3 hours CEU. So hopefully, if you've not checked out the Missouri Credentialing Board MCB website, you will go and do that and see what trainings they offer. They don't only offer for for community health workers. They offer for peer specialists, a lot of different certifications. Challenges, not a completely billable service. There are some of the services, as Tim talked about earlier, that are billable, but you have to be creative in finding those dollars to be able to make CHWs a sustainable business or sustainable part of whatever organization that you're a part of. And another thing with challenges is so many changes occurring with Medicaid and other benefits. Sometimes it's hard to keep up. I know that our community health workers from the organization I worked with before were all able to do Medicaid applications. A lot of them were able to get into the actual Medicaid portal to look up things, but those changes are happening so quickly right now. They work very closely with the Missouri Primary Care Association to make sure that they don't miss any of those opportunities. So this is a little bit again about the Community Health Worker Echo. It's the first and third Tuesday from 2 to 3 p.m. It's always, those are the set times. We typically start those up in September and then they run all the way through the end of June. We take a break in July and August and then start back up again. You can join in at any time. It doesn't matter. And then you'll get a certificate of participation that you can utilize as well for the needs that you may have. Lastly here, this is my contact information. I also put on here the website for the Community Health Worker Association, for the Missouri Credentialing Board, for the National Association of Community Health Workers, and then also for DHSS on their things about community health workers and the certification course if anyone is in need of it. So that is the end of my presentation.
I have a couple of questions in the chat.
Fantastic. Well, boy, what a great, I mean, I learned a ton and I can't thank all of you enough for coming and presenting and sharing. And I know that there's some questions in the chat and I have questions for everybody, but as I'm looking and figuring out where the chat is, I just wanted to have a little bit more of a discussion with, you know, Tim and Christian and Hanaid about, you know, I learned a lot about the fact that there's now, you know, billing codes and apparently a sustainable model for supporting it. But what's not clear to me is who receives those codes. Is it the hospitals or the health systems for making the referrals? Obviously, there are codes for the delivery of the referrals. We somehow don't, it doesn't seem like it makes a lot of sense for hospitals to start employing CHWs, and we certainly don't want to undermine the CBOs that are actually providing the services that you know, we're trying to arrange and support for our patients. So I was wondering if the three of you could have a dialogue about some of the implications of these new billing codes, who would bill for them, how they would be done, and what are the ripple effects for the future of organizing such patient-centered infrastructure for care. So, I mean, come on up and chat, because I don't think, is Tim still on or?
Ask him, talk into the mic and ask Tim to.
Yeah, Tim, are you on?
Yes, they are.
Oh, good. So if you could unmute and Hanaid and Christy, if you guys could come up, I'd love to hear some of that addressed.
I'll speak to a few points and then Hanaid has worked heavily in this space. I know Tim has run some calculations in terms of how to justify payment of a community health worker, for example, using those codes. We have collectively in the community provided feedback on some of the earlier RFIs. It's a bit problematic currently. It's a great step. I'm so glad that there's good outcomes from the Accountable Health
The MMI project.
Yes, yes. And I'm glad that there are codes starting. Reimbursement conversations have been going on for a long, long time. However, one of the problems is that it has to start with a clinical referral. And yes, it's a clinical billing code. So in theory, they could bill the code. They could use those funds to work with CBOs. Many of them are probably hiring community health workers, which again, community health workers are important no matter where they are. However, I think we're missing a big piece of the puzzle here. CMS is really designed to pay folks with clinical backgrounds with an NPI. So the structure is problematic. However, until we can initiate those referrals in the community, it becomes challenging. And that's a plus for clinical settings as well, because you think about how many clinical settings have attributed patients, but they can't find them. They don't come regularly. There's not continuity of care, and the community can help with that. But if we're waiting on a referral from the clinical setting, it really slows that process or even overlooks it entirely. So that's the one comment I would have. Henny or Tim?
Don't go so fast.
Okay.
It's a pretty follow-up question to that. You're saying like as of now, unless the CHW is actually by the HC, there's no reimbursement. Is that correct?
The billing happens in a clinical setting. The funding comes into the clinical setting. We could argue that you should use that funding. That's justification to invest in CBOs who employ community health workers in the community. There are some things to think through in terms of if I'm a physician and I'm billing that code, what's my liability for that care actually happening in the community? So devil's in the details, but it's a conversation worthy of having.
Can a health facility sort of contract with the CBO? So if a CBO provides 4 hours of service, even though that's not a health system employee, can the health system bill for that and then give that back to the CBO?
Yes, in fact, I think that's happening. Of course, we advocate for the network because there are centralized administrative services there. So CBOs then can focus on that client-facing service as opposed to our computer system, contracting, invoicing. If we can streamline that and do that in one place, then as that money flows to the CBO, it's really going into the client support, participant support.
Is there any effort or model where you can make it easy for a hospital to do that? Like I'm just thinking, and this was actually my question for Sharita is, you know, I'm a cardiologist. I practice at Truman. I mean, I have no idea. And, you know, all my patients have SDOH challenges. I have no idea how to sort of access that. And so it seems like, you know, there ought to be a infrastructure for the hospital to invest in, or the clinic to invest in, to sort of leverage some of their mandatory SDOH screenings, but to make it easy to sort of make a referral, which was what was so great about what the CSN is doing in our heart failure project. But you know, I know none of the hospitals are billing for the contact hours you actually have, even though I assume you would provide the documentation so they could do so. So how do we create a working model? You know, it's like the easy button. You know, how do we push the easy button so that people know how to do this? It seems like it would create a much more sustainable infrastructure for what you're trying to do, because, I mean, the hospitals could cover their administrative costs a little bit, but most of the money would go to supporting the CSN, the CHWs, whatever organization could make that easy.
You want to hear my dream?
Yes. Aspirational. Yes.
That's right. We got to think outside the box.
And speak closer to the mic.
Sorry. Apologies. Yeah. Yeah. So if you allow me to dream a moment, I recognize that this is, it would probably cause a lot of reaction, but if you think about that slide where healthcare entities are worried about capacity and CBOs are worried about sustainable funding, we've got to not continue to look for each and every dollar, and we've got to not look at this as a referral episodic based payment kind of situation. In other words, yes, there's an easy button with network. They can just make the phone call if they have a social determinants of health positive screening. We can activate the CBOs and their community health workers to provide those services. But that fluctuates, right? And oftentimes in these large organizations that from time to time have tight belts, the first thing to go is that community support. So it's just far too volatile. So my dream is to think about, and I'm going to also add, CMMI did a number of model tests, and they learned early on that 3 years is not enough to show an outcome. 3 years is challenging. So the next CPC Plus, for example, Comprehensive Primary Care Plus initiative was 5 years. And then the latest one, Making Care Primary, was 10 years, unfortunately just got canceled. So we're learning that evaluation takes a while to really see those lag measures like cost. We can see a lot of process measures. So my dream is that there would be a capitated payment model for 5 years, a commitment to 5 years. In other words, we're not just going to pilot this or try it for a year. And you can imagine that the healthcare entity then knows what their budget is for that 5 years. They can work it into their system. They can know that's an investment that they're making for those 5 years. The CBO then can hire community health workers and train them and have the confidence that they have a working budget to look ahead to, of course, up to a certain point of support. So don't know if we can get there quickly, but in order to make this a reliable model, I think we've got to stop having the conversation about, number one, is it effective? It's there, it's in the literature, it's now in this third evaluation. We have to stop trying to reprove it. And we also have to stop churning these few dollars that aren't consistent.
But don't these new payment codes and models create a business case so a hospital could make a 5-year commitment? And as long as they're using the services enough, and especially if they're able to bill for the services delivered by the CHWs, that it could be relatively cost neutral and meet their community mission, at least for the nonprofits. I mean, I guess I'm just wondering if we're at a new era where your dream could come true as long as somebody could lay out the business case for the hospital on the net savings, and especially in the Medicare Advantage patients where a lot of the hospitals would be at risk for the total costs of care, and the payers as well, that they would now have an even greater incentive besides hopefully the cost neutrality of doing the services, but then the opportunity to benefit more from shared savings. I mean, are we not at that moment or not? And if we are at that moment, how do we create awareness? How do we build the easy button and get the 5-year, 10-year commitments you need?
Mm-hmm. I can give you an example from a few years ago. Gosh, more than I care to admit at this point, but one of the early healthcare innovation awards was won by one of the subsidiaries of the American Academy of Family Physicians, and I had the great honor of leading that with 15 hospital health systems across the eastern part of the country. We were heavily fee-for-service. I would almost say solely fee-for-service, and those hospital health systems did not want us to work on decreasing ED or decreasing admissions, and they certainly didn't want to invest in population health staff, like a care manager who would support high-risk folks. The chronic care management and TCM, transitional care management codes came out about that time. We had raw claims data at the time, so we could look at their attributed patients, those that were high risk. We could apply that funding backward, and we could go to the hospital CFOs and say, if you start using this code, had you used it last year, you would have made, in some cases, $5 million. Now, can you hire a care manager? Can you begin to do population health? And is it really good care for those 10 patients who are coming into your ED every week, every month? Let's at least talk about those. So yes, once the codes are there, then we can start to talk about at least investing. Yes. Yeah. So there we were in a fee-for-service model with hospital health systems, and we were one of only 2 that showed increasing utilization in those early days. So yes, it can work, but you got to speak the language. Yeah.
I'm going to show my lack of knowledge quickly. Patient navigator programs that existed a number of years, some of them still exist. They funded by the institutions more by CHWs and the health worker that we're talking about today being necessarily extension services at the institution. It's just an impression I have. Right? Wrong?
Right, so I wanted to clarify about navigators. Are we talking about the Affordable Care Act navigators that were in the area to help people sign up for insurance?
To help the cardiovascular patient get system coordination services. etc. I know at one point, I was on the board a long time ago, we had cancer for
I think it really varied depending on the entity. So for example, some clinics might have had navigators that were dedicated to provide information on insurance. So Affordable Care Act, which plans, kind of that neutral party that's really able to educate the community on what insurance is and what might be the best fit for them. And then they were connected to a CHW. They're referred sometimes within their own organization, and then to kind of be able to be enrolled and address those different barriers. But kind of, I think, if I were to go back 10 years, maybe when that program started, as a CHW, we were trained as part of the kind of that ACA navigator, and then we were kind of split. Because the navigators, well, one, there was a few of them and were very dedicated to kind of that specialty, but then people with higher needs were referred to us in our CHW program and enrolled and continued working with them, depending on how much time they needed enrollment. So it was a little bit different. So I think that role is maybe what you're talking about. That was primarily, again, Affordable Care Act specific. I'm not sure if other entities might have had. Sorry. I believe.
Figure out if we were talking about funding. So I was trying to figure out, and it's John's question, essentially, who's actually paid for these services. Great, we have codes, but.
So the navigators, I think, were a CMS fund. Gotcha. For example, the navigators, for as far as I knew, they were funded by CMS specifically. So those were the funds that were coming, which I think last month we got notice that, or there was a notice out that 90% of the funding was going to be reduced for all navigator programs. So then the way, for example, where I worked, the navigators had their CMS funding, and then CHWs, we had different pieces depending who we were kind of contracted with, whether it was a hospital, FQHC before there were FQHCs, or maybe some sort of school, different program. So that's where the funding came. So it was all of piecing together and trying to move along. So then CHWs, because we did have a 3-year program, 1-year grant, 2-year grant, 5-year grant, we moved quite a bit as well. So the funding did come from different streamlines as far as I can tell, but not necessarily one big bucket of anything.
I'm still on this subject from the chat line. I have 2 questions on this and then a couple of other chat questions for that, but has there been any consideration of a closed loop referral system? And went away. Oh, what are the reimbursement rates for those billable codes? Is that?
Yeah, I think those were shared, and they were sort of $75 to $80 for the first hour and then $35 for the second. But if Shelby's on the phone, it'd be great for her to ask her question live and get feedback.
I know that Tim's not on the line, but so regarding the codes for Medicare, there also, as far as I know, there's not a limit on how many hours can be billed. So he mentioned that it has to be at least 1 hour billed before you can bill them. But as far as my understanding is, once their client is enrolled, there is not a limit of some programs. And I think the state of Kansas might have had one that was sunsetting last year, that I think it was just only 1 hour per month or 5 hours per month. As far as I know, as long as the health-related social needs, it is identified, continues working, there is not a limit of how many hours can be billed for that particular beneficiary. So just a side note.
Emma was interested in the experience community health workers had with navigating managed care organization relationship.
That may be a Rita question.
Yes. Ridge would be interested in the experience community health workers have had navigating managed care organization relationships and reimbursement.
You got it. We need you up here.
Suzanne might want to jump in on that one as well.
Could you repeat that? Because it's hard to hear sometimes from the audience.
Rita, go ahead and speak and then we'll.
Yes.
I think, yeah, repeat the question.
Yeah. The experience community health workers have had navigating managed care organization relationships and reimbursement. That's what we're addressing.
Oh, okay,
Yeah, you could
yes.
repeat the question because people online can't hear Pat.
Yeah.
Where we go, find it here. Hang on. Okay. Interested in experience CHWs have had with navigating managed care or relationships and reimbursement. Reimbursement, I haven't received any reimbursement from community health work. I'll just be honest with you, there's no reimbursement for me. But when it comes to managed care, it's just the standard, it's the standard navigation with helping all of the community members that do come into the clinics that we have the opportunity to team up with. So that would be, I would believe that would be more on the back end with the admin administration and how they manage those when it comes to reimbursement, because I don't really know much about it.
And invite Suzanne, because she's in that too.
Sure.
Yeah.
I can't wait for Suzanne.
Suzanne, can you hear?
You're cutting in and out. That's why if you're not at the mic, it's very hard to hear what is being said.
How about now? Is this better?
That's better. Yeah.
Oh, sorry about that. Should I repeat what I said?
No, I heard what you said.
Okay.
I can't hear what's being asked out
Okay.
away from the mic.
Yeah. Sorry.
Hi, this is Sinead. Suzanne, folks were inviting you to chime in the same question.
Okay, can you repeat that question? I guess is what I'm
Yes,
saying. I'm sorry.
absolutely. The question is about if folks being interested in the experience CHWs have had navigating managed care relationships and reimbursement.
I think it depends on your organization. A lot of times, I know when I was with an FQHC, they also had RNs and LPNs that were doing managed care, and they were billing for those. So you couldn't also bill for the community health worker. And they wanted to bill for the nursing part of it because they were trying to offset those costs. But working out in the community where a lot of us work without being associated with the CBOs and FQHCs, it's very difficult because there's not that opportunity for reimbursement. Does that help any?
I think so. Yes, thank you, Suzanne. I was going to add in some of the work that we're doing in the collaborative as well around reimbursement. So we mentioned the CHW reimbursement toolkit earlier, and a lot of it also has to do with us being able to host those webinars to be able to educate CHWs on what reimbursement might look like at the institutions, as well as this year being able to develop additional training depending on employers or CHWs to be able to learn more, one, about the process, awareness, and our focus primarily being Medicare, as well as in the state of Kansas, probably opening a can of worms right now. The state of Kansas having the state plan amendment from last year and being able to have a reimbursement code for CHWs through, again, some of their programs. So those are two of the things that we're focusing on quite a bit this year. Again, in order to support sustainability, and we know that it comes with a lot of different questions, and we look forward to share that information with folks throughout the year as we have it available. I'd like to ask Marlene Nagel, do we have any other additions for that?
I think the only other thing on the MCOs that I would suggest is that we are hearing that some of them are actually hiring community health workers to work out of their operations. They tend to do their work by phone or virtually rather than sort of in person, which is sort of the hallmark of a community health worker, being able to be with the client or the patient, building that trust and helping them. And I think as we do more with managed care organizations, hopefully they will see the opportunity to partner with, whether it's with a healthcare organization or a community-based organization, to make use of community health workers who are in the community providing that service.
Well, we're coming to the close of the session. I do hope that there's going to be more interaction. I also really hope that we can have an update in 12 to 18 months, because I really can't emphasize enough how, at least from my perspective, the medical profession really is unaware of the value and how to link in. And then also from your end, how to give feedback to reinforce the benefits of making the effort. And I think, I just can't imagine with, the Herculean accomplishment to actually get codes, there isn't a way to figure out how to create a more, every hospital is shaking its boots. When that $880 billion doesn't comes out of Health and Human Services, but not out of Medicare, the impact is going to be horrifying. So it's going to be hard to get them to just invest in CBOs and other organizations, but creating a regional business plan that could really make it easy for them to know how to bill, get the billing in, and then dole it out, and that they in turn could benefit from the better care their patients get seems remarkable to me. And so you have a huge challenge ahead of you, but you've had to do it for decades with much greater headwinds than this. So I hope you can seize this opportunity. And I thank everybody for, participating, presenting. Our presenters were amazing. I learned a tremendous amount. And then in 2 months, we're going to be talking about AI. So I think that that's a very disruptive aspect of healthcare delivery. And I really look forward to that as well. But thank you all so much for participating in today's forum.